RetinaRounds Episode 2, Post-operative macular fold. How do you fix a macular fold after retinal detachment repair? This patient underwent a scleral buckling procedure for a macula involving retinal detachment using a 276 tire. There was incomplete subretinal fluid drainage, and so the decision was made by the surgeon to inject an expansile bubble of C3F8 gas to tampen out the break and assist with resorption of subretinal fluid. However, the patient did not position face down and unfortunately presented with a macular fold on postoperative day 1. You can see the OCT on postoperative day 1. There's significant folds of the macula, particularly the outer retina, which is involving the fovea. This was observed over the course of 1 month, and you can see the fold significantly improved, but there's still a persistent fold involving the fovea, and the patient is reporting significant metamorphosia that's interfering with his daily life. So the decision was made to take the patient back to the operating room in order to fix the macular fold. Here we're doing a standard 3-port pars plana vitrectomy and using tissue blue to stain the ILM. This was left in the eye for approximately 1 minute. You can see the fellow now initiating an ILM flap using the pinch and peel technique. He's starting proximal to a retinal blood vessel. This is a good location to start since the ILM tends to be easier to fracture in this location. He's also starting in the inferior macula, which in some cases may be ergonomically a little bit easier to access, but more important, if there is any injury to the inner retina and any associated scotoma, it's going to be in an area of the visual field that's less bothersome for the patient. Once that initial strip of ILM is removed, you can see that there's a broader edge that can be used to initiate an ILM flap, and that can be used to extend the peel over the surface of the macula. The purpose of the ILM peeling in this case is to create some laxity to the retina, but as you recall from the OCT, the folds are primarily involving the outer retina. So peeling the ILM here is probably not going to be sufficient. Once the ILM peeling is completed, we're going to use a subretinal cannula to inject BSS into the macular fold. And what that's going to do is it's going to dissect apart the adhesions of the outer retina to allow for adequate flattening of the macular fold. You can see the fellow showing really nice control peeling the ILM, very nice and stable. However, there's a number of strips of ILM that are being peeled rather than one continuous flap. This can be mitigated by having a broader base to the flap, peeling more slowly, and redirecting if there's any signs of shearing, and also limiting the antero-posterior pulling of the flap, which can much more easily shear it off the surface of the retina. Here you can see the BSS being injected using a subretinal cannula into the macular fold. And the tip may be a little bit difficult to see, but it's located right here. Most of that fluid is dissecting the fold anteriorly towards the buccal, but some of that fluid, it's a bit hard to appreciate in this video, but some of that fluid is going posteriorly towards the fovea and releasing some of those adhesions of the outer retina. Once those outer retinal adhesions have been unfolded, we then instill perfluorocarbon liquid over the posterior pole to steamroll the macula flat. You can see here the PFL is being slowly instilled to avoid any turbulence, to avoid any bubbles, and then an air fluid exchange is being performed to remove the subretinal fluid and completely flatten the retina. Then endolaser is applied around the retinal break. Non-expansile SF6 gas was instilled into the posterior segment. And here you can see the patient's postoperative outcome. This is at postoperative week 1. And you can see the folds have markedly improved. Here's the postoperative OCT, and you can see the macular folds have completely resolved. Most important, you can see in the fovea that there is continuity of the ellipsoid zone, and this patient's vision improved to 20/25, but more important for the patient, his metamorphosia resolved. Here are your take-home points. The risk factors for developing a postoperative macular fold include residual subretinal fluid, especially if it's a superior retinal detachment and a partial gas fill. When there's a superior retinal detachment and partial gas fill, the gas floats to the top of the eye and pushes that subretinal fluid inferiorly. If the detachment is splitting the macula, the fold will occur at the interface between the attached and detached retina. This can be mitigated by face-down positioning to avoid the gravitational effect of a superior buoyant gas bubble pushing subretinal fluid down towards the interface of the attached and detached retina. And therefore, patients who don't position face down, who have these risk factors, are at higher risk for developing macular folds. Scleral buckles also place patients at a higher risk for developing macular folds, and that's because there's increased redundancy of the retina with the scleral buckle. Oftentimes with scleral buckles, we can see peripheral retinal folds in the early postoperative period. Those tend to relax as time goes by. However, if you have a combination of these factors, a superior retinal detachment, partial gas fill, patient doesn't position face down, and a scleral buckle, this is a setup for developing a macular fold, as is demonstrated in this case. When a postoperative macular fold is resulting in decreased vision or metamorphosia for a patient, the technique for repairing the macular fold involves peeling the ILM to increase the laxity of the retina and injecting balanced salt solution into the macular fold using a subretinal cannula. What this does is it opens the leaflets, the adhesions of the inner retina, so that the macular fold can flatten. It's important to drain subretinal fluid. This can be achieved either through a peripheral retinotomy, as is demonstrated through this case, or a posterior drainage retinotomy. Once the subretinal fluid has been drained, a complete gas fill can be achieved, and the patient should be positioned in the face-down position to promote flattening of the macular folds. If you enjoyed this video, please visit us at RetinaRounds.com. There you can sign up for our email list. You'll get a notification every time a new video is posted. And if you have an interesting video or a tip or trick that you'd like to share, please follow the links on our website and you can upload your video there. Thanks so much for watching.